Welcome, everyone. This is Liza Greenberg with the Patient-Centered Primary Care Collaborative Support and Alignment Network. We're so delighted to have everyone with us today. This is the fourth of 5 calls that are part of our Pediatric Learning Network. Our work today is on adopting person and family engagement strategies to improve pediatric asthma care. And today we have with us our quality improvement leader, Ruth Gabernick, who's been the leader of our calls all along. And we have 3 practice innovators who are going to share with us some of their work: Diane Weiss, Casey Jenkins, and Dr. Ashraf Afan, Rolando Lozano, and I'm Liza Greenberg, our facilitator today. And as those of you who have been on prior calls know, our goal is to reduce hospital admissions for asthma by improving quality of care, and we'll do that by emphasizing person and family engagement strategies. So we're talking about ways that patients and families can participate in shared decision-making, in being activated around treatment objectives, addressing issues such as health literacy and other issues that impact patient engagement and activation, and then using tools to try to develop engagement strategies in ways that work for patients. So today we're going to discuss a number of innovative pediatric practices. We'll talk about some of the ways that practices have adopted e-tools. We'll talk specifically about registries, and then we'll discuss what we've heard from coaches and practices along the way in order to kind of replicate and amplify the work that other organizations are doing. And just so we can sort of place ourselves in the curriculum, we're working today on one of the person and family engagement metrics developed as part of the Transforming Clinical Practice Initiative, and it's working on the issue of e-tools. And here is an overview of the measures. We've worked, I think, on almost all of them so far because they do intersect with each other. And the approach really is that we integrate all of the strategies as we work with patients and their families on specific asthma quality improvement activities. And I just wanted to show you our framework, which is to take the TCPI, person and family engagement measures, and really show how that they apply to different aspects of asthma quality care. So the message that we'd like to come away with is that person and family engagement is not a separate activity that an organization needs to do, but it's an integrated approach that will help the work that you do every day with every single patient. And so why don't I turn it over to Ruth, who will lead us through our curriculum today and who will also help introduce you to our practice innovators. So thank you, Ruth.
Thanks, Liza. Good afternoon, everybody. You've seen this slide before. I've popped it up each time as the ARC definition of patient and family engagement. Just a chance to just take a second and remind everybody that, this is about the need for patients and families to be actively engaged at all levels of healthcare, and certainly the pediatric primary care being part of that. That there's a need to ensure free flow of information to and from the patients and families and the environment where the patients and families are, where they're always treated with respect. So I know we all keep that in mind on a daily basis, but also just gives us a frame of reference. So next slide, please. This afternoon, we are really pleased to have 3 pediatric practice innovators who have volunteered their time today to share some of the work that they've been doing that impacts the metrics, the goal of this project, and metrics specifically regarding person and family engagement. I'd just like to say that we would like to answer any questions that you may have, but please write any questions into the chat box, and then we will answer the questions at the end of all 3, at the end after all 3 of our practice innovators have shared their work with you. Okay, so, and please don't be bashful if you have any questions or comments, or we'd like to hear from you. So first, I would like to introduce our first practice innovator this afternoon, and it's Diane Weiss, who her official title is the parenting specialist with Weiss Pediatric Care, but I know that she has a lot of roles and responsibilities, and she is going to share with you an example of the person and family transformation work that they've been working on related to asthma care management. So I'm going to turn this over to Diane to give you also a little background about their practice.
Hi, Ruth. Thank you very much. We are a very small practice in Sarasota, Florida. We have a solo practice and 2 half-time nurse practitioners. We opened this practice 4 years ago. Dr. Weiss was with a larger group, and 4 years ago we decided that by combining my work as a parenting child development specialist and his pediatric care, we'd have a head start on creating the patient-centered medical home that we were hoping to develop, and spent the first 1.5 years working with the Florida Pediatric Medical Home Demonstration Project, laying the foundation for our work here. And so I'm quite honored to have an opportunity to share our very small quality improvement activity with you today. Because we are so small, I feel very humbled by all of you who are working on a much larger scale. I have to say that when I think about quality improvement activities, I think of it kind of like a circus act where you're spinning plates. You know, you identify your quality improvement activity, you do your PDSAs, you think you have protocols in place and things are running smoothly, and so you take your eye off of that plate and start to spin others, and you have several activities in motion at one time, and then school physical season hits, or like in our case, our front office person for a year just decides to leave, or we're working night and day on our PCMH recognition application, and you go back to check some of your quality measures like our asthma care, and you realize that, you know, maybe we've kind of diverged from where we had been heading. The flow had kind of gotten loose, and so you start spinning the plate again. I just think quality improvement is just such a difficult process and to maintain. And so when we were working on our must-pass 4B standard for PCMH recognition, I thought we had our asthma care plans all in line, and it turned out when I ran our numbers, in fact, we weren't scheduling our follow-ups the way I thought we were, and we were having trouble getting parents to come back in. And there were a couple of reasons for, I think, parents canceling those follow-up visits, not following through. First and foremost, I think they on the whole can't understand why they should come in for regular follow-ups when their child is in the middle of a flare. So it's kind of the same education process that we have to follow with our well visits. Why do you bring a child in for a well visit? But I think we had fallen off the wagon a little bit with our education when it came to helping our parents understand the importance of regular asthma follow-up, and we had certainly not been recalling the way we should. And so we did, as part of our sprint plan, our quality improvement plan, target our children with moderate severe asthma, moderate persistent asthma, that had not been seen in the past 6 months for an asthma care plan, to get them in the office, and then to schedule a 3-month follow-up like we do, scheduling well visit follow-ups while children are here for their current well visit. And I set a fairly low bar of 30%, thinking 30% of those who are overdue would come in for their asthma care plans. And of course, the first thing we did was run a report of all of our children with moderate persistent asthma, and who had not been seen in 6 months. And it turned out in our teeny practice that constituted only 18 patients. And we did call them in, and we have gotten 9 of the 18 in and scheduled them for their 3-month follow-up. At each visit, we decided we would be more vigilant about offering a pre-visit questionnaire so that we could be sure that we were answering questions our families had, that we got a sense of how they understood their medications and the use of the medications, and that we were aligning our conversations with their goals. So at these asthma care visits, we developed and are using educational materials that describe the different kinds of asthma care visits that are so important, including making sure that these families understand the importance of flu vaccines and well visits and advice around their medications. And then we developed a little bit more lengthy handout that talks about the symptoms of asthma, the management of asthma, all geared to our parents to augment the conversations they're having with Dr. Weiss. All of our children who are 6 years and older, of course, are getting spirometry at the time of those visits. Our children who can do spirometry. And then the asthma care plan is either developed or it is reviewed and updated at these asthma care plan visits. And as I said, 3-month follow-ups are scheduled, and we were not as consistent as we thought we were being, making sure that those 3-month follow-up visits were scheduled. And then we saw that even when we scheduled them, parents were often canceling them. So we're still working on that. Next slide, please. This is a lot of words on a page. It's mostly so I'll remember what to tell you. That actually, when these slides were developed just a few days ago, 18 patients were identified. 3 of the 18 turned out are being followed by pulmonology, so they are not part of our recall right now in terms of getting them in for their care plans right now. 9 of the 18 from the time we started this project, I guess it was June we started it, July. 9 of the 18 have been seen for their follow-up, for their asthma care plan, and a 3-month visit has been scheduled, a follow-up visit. And since this report was done, we actually we have 2 more scheduled, so that'll bring us to 11 of the 18 who are either scheduled or have been seen for their asthma care plan. Interestingly enough, of the 9 that we were looking at a week ago who have been seen, 6 of the 9 actually had their diagnosis modified from moderate persistent to mild persistent or mild intermittent. We will continue to work to get some of these the rest of the families in. One of them has refused to come in. A couple of them have not returned our messages. One of the remaining ones actually, upon review of the 18, didn't qualify. What I think is so evident is that there are challenges inherent in this particular quality improvement activity, and I think in so many. Even in a tiny practice like ours, staying on top of recall is so difficult to make sure we're running those recall reports regularly and following up on them. We only have 5 full-time employees in our practice. Everyone wears multiple hats, and somehow these recall lists fall to the bottom of our to-dos so often, and so that continues to be a challenge. We were working through this quality improvement activity during school physical season. Do I need to say more for all of you who are out there in pediatrics? And we realized that these visits, because they are so filled with education, conversation, spirometry, development of a plan in collaboration with families, that they really take 45 minutes. It's tough to find those 45-minute appointments, and it's also impossible to get paid for them. So just some of the challenges that we've faced, and then successes. We have had taken a sampling of the 9 families who did come in for their asthma care plans and are scheduled for follow-up, and their informal comments have been very, very positive. It seems that our pulmonologists are not producing the same kind of care plans that we are. From several of our families who had been to pulmonologists, they said they never even received these kind of care plans from the pulmonologists. So that is our quality improvement activity in a nutshell. And if there are questions, I'm happy to answer them. Ruth, is there anything else I can add?
No, that we appreciated you sharing. I think that probably even in large organizations that there are a lot of heads nodding that, you know, they identify with those lessons that you learned and some of your challenges, And I think it's not, as you know, quality improvement is not just about the number of patients, but the fact to see at the bottom that those that you were able to get back in, that they had positive things to say about that that engagement, that opportunity for engagement that you had, you're to be commended for that. So don't discount the size of your organization. I think I heard lessons that we can all learn from, and that each of the coaches can take back to their practice teams that they're working with, regardless of size. So thank you for sharing that.
Sure.
So great, thank you. And I'm going to introduce you all next to another practice, a pediatric practice innovator team, Casey Jenkins and Dr. Afan, who are involved with Angel Care Pediatrics in Jacksonville, Florida. And they're going to share with you also the sprint plan that they've been working on to reduce healthcare costs related to their patients with asthma and opportunity to improve care quality. So again, if you have any questions, please put them in the chat box.
Thank you so much for having us. Thank you so much. My name is Casey Jenkins, and I have Dr. Afan here with me. I am the Quality Improvement Coordinator here at Angel Kids Pediatrics. And like it was said, we're in Jacksonville, Florida. We are the largest pediatric practice here in Jacksonville. We have 6 locations, over 22 providers. We have a large patient volume. And asthma, like was said before with the quality improvement, we're in the process of recertifying our PCMH. So, of course, things you kind of take your eye off of it. And we have done extremely well with our different protocols to manage chronic conditions. However, I think when we started reviewing some of our managed care reports from those companies, we started seeing that it wasn't matching the numbers that were being pulled in our EMR. So, of course, we did a little bit of a deep dive. And I don't think we were using our EMR to its fullest capability. So we weren't identifying these patients like we thought we were. And another thing that we had noticed was that our ER utilizations were high. So we do have a lot of emergency rooms, urgent cares, and that is one of the biggest issues we face here in Jacksonville, is that sometimes the patients feel that it's easier just to go to the ER rather than come to their primary care, even if we have extended hours. So that's basically what our plan focused on. If you want to go to the next slide, please. So like I said, we wanted to focus on those ER visits. So we have extended hours at our beach location, and all of our 6 locations are kind of scattered across Jacksonville. So, I mean, from anywhere in Jacksonville, we have a clinic within 10 to 15 minutes. So we were kind of puzzled why our patients were going to the ER instead of coming to us, even if we had these extended hours at our beach location. We're open Monday through Friday until 9 p.m. and Saturday and Sunday from 9 to 4. So this was something that we thought, well, maybe if we do an analysis, we can kind of see where these patients are. So after looking at those reports, we noticed that they were going to the ER even during business hours. For things that we definitely could have handled in the office. So we knew that we needed to take some steps and get some education for our patients. So we extended the hours at our Bartram location, which we did have our hours from 9 to 9 Monday through Thursday, but we decided to open up our Friday evenings as well, which did help significantly. And we also moved one of our offices to a different location and extended those hours until 7 p.m. So that gave us 3 locations with extended hours. We increased the access, tried to educate the patients of that increased access. We hired care coordinators. We have 2 currently, and they receive all ER visits, reports, any calls. They're really the ones who do all of the care coordination for our patients. So anytime an asthma patient came through, they knew exactly how to handle that based on our sprint plan. So we wanted to outreach to these patients and get them in for a follow-up, and then also see what was happening, why did they go to the ERs, or something else that we can do to prevent that unnecessary utilization if it was something that we could in fact handle in the office. So like I said previously, our technology, we weren't necessarily using it the way that we could. So our EMR has an asthma action plan, which is great. We've used it. We've had great success with it. However, we did not have a care plan integrated into our EMR. So for our sprint plan, we used evidence-based guidelines that Dr. Afan and other providers had set, and we went in on the back end, had put those in, so there were triggers and actions associated with those. So when a patient met that trigger, it would flag that patient, a pop-up message would come up. So if anyone was going into that chart, they would know, hey, I need to pay attention to this patient. Additionally, with our daily huddles in the mornings, everyone would go through the schedule with their office manager, and if one of those asthmatic patients was on there, they knew, hey, we need to pay special attention, like let's make sure that this patient gets the care that they need. So we tried to kind of tackle it on two ways, with technology and with teamwork, and we had great results. One thing that kind of was frustrating for us was that our two sets of reports were not matching, like I had mentioned previously. So we had to do a lot of data cleaning and a lot of hard manual labor to find those patients, update their information, make sure that it's a SNOMED code versus ICD-10, all of the technicalities that would cause a patient to kind of slip through the cracks to not pull in with those reports. So once we got all of the hard stuff taken care of, the rest was pretty easy. If you could go to the next slide, please. So one of our goals was to see our patients within 7 days of the ED. Now, out of this number, we compared 2 of our managed care reports, one from the first quarter and one from the second quarter, which the second quarter was during the sprint plan. And we did see a significant decrease in the number of asthma visits going to the ER and an increase of our asthmatic patients coming to us, which was really good to see. And then out of those patients, we had 29 that still went to the ER, and out of those we had 7 that came in, so that was 24%. Now out of those patients, it's a little skewed because some of those are assigned to our panel, and we reach out, but we can only do so much. But out of our patients, it still was a fairly good, significant improvement. And then additionally, we reviewed the ER utilization reports weekly in our huddles. I think this was really great to see the team come together and kind of go over all of the pieces and really see everything connect. I think with quality improvement, there's so much clinical and different things going on, administrative processes, that quality improvement, a lot of times people don't understand what it is or how it applies. So it was really beautiful seeing everyone understand each other's roles. So it definitely made our workflow a lot better. Our patient portal use, that increased by almost 7%. We found out that we had a lot of people accessing their patient portal, but they weren't actually using it. And they can access their asthma care plan, their action plan, all through their portal. They can request their medications, appointments. So that was a big piece. We wanted to get people actually using that. And luckily, with it being the summertime, we had some high school students who were happy to volunteer and get some hours to help sign people up for that. And then additionally, we had the number of patients in our care plan enrollment. Trying to match that to our insurance report, we had the accuracy increased by 69%. Originally, it was at about 50-50. So we did try to clean up a lot of that data, but of course, it's constantly changing. Each report we get totally new data. So that is something that we're still trying to work on. So like I said, it's a little difficult with the data that's provided and the timeliness. These are two huge things trying to work with when you're trying to assess where you're at. If the data is too late or not correct, it's kind of hard to gauge where you're at and where you want to be. So that was one struggle for us. And then the second was communication with the ED and patients. So we've been trying to improve our communications with the emergency department, having 6 different offices with different faxes. Things kind of go to different offices and sometimes don't make it to the place it was meant to go. So we've tried to improve those communications, kind of streamline some of those processes because we did grow so fast. We did not intend for a lot of that to happen. And then also with patients, we've been trying to update patient information. A lot of phone numbers change, addresses, so just trying to make sure that we have the correct information, that we keep those lines of communication open with those patients. That was very difficult, but we're working hard at it. So the beauty of all of it that we did, we were really thrilled. Just comparing the first quarter and second quarter, we had a 42% reduction in the asthma-related ED visits. And then we had a 66% cost reduction. So comparing the 2 quarters, we had about a difference of $25,710 that were saved between those 2 quarters. And this was just for one managed care plan. It is our largest. They comprise of, I would say, about 50% of our patients. So it was pretty significant seeing that number on things. If we just put in a little extra effort on our end, how much of an impact that could have. And not only does it save money, but it improves the quality of life for our patients. So that was really great seeing how everyone came together to make a difference. And that's about all for us.
Nice.
Do you have anything
wow,
you want to add?
great.
I'm good. Thank you. Wait for any questions.
Yep.
I thank you for explaining some of the interventions you've used, also for the trying to improve communication with the emergency department, and in addition to with your patients, and how you've been using the utilization reports that you get. But it sounds like you're working directly with the EDs. Or, even though that's hard work and ongoing, it sounds like that can help some of the timeliness that you've been struggling with to get information. So that's good. Nice to hear about your use of technology, both on your end as a practice, but also on for the patients and families, and the increase of portal use. So thank you. And that leads us to our third practice innovator. Rolando Lozano is from Springfield Pediatrics here in Springfield, New Jersey, is going to share with us this afternoon some of the strategies that they've used to be able to specifically increase the use of their patient portal, and some of their successes and challenges and lessons learned. So Rolando, it's all yours.
Thank you very much, Ruth. Good afternoon to everybody on the call. My name is Rolando. I'm the practice manager for Springfield Pediatrics. We're a small pediatric practice. We have 3 locations throughout Union County in New Jersey, and we primarily deal with a large population of Spanish speakers, or first-generation immigrants, new to the country, haven't grasped the language. So that was an obstacle that we faced when trying to implement the use of a company website and a patient portal, because a lot of these people either were uneducated into the ability to use such a system, or felt that if we were asking them for more than the basic information, that we were going to report them or sell their information to somebody else. So at the beginning, we had a lot of pushback from our patient population, to be honest. You ask, hey, do you have an email address? No, I don't have one. No, I don't use it. No, I don't understand. So that was a constant issue, and we were seeing that, we weren't reaching our goal in terms of getting people to use the patient portal. But actually, within the past few months, with working actually with Ruth to get our practice to be PCMH certified, we actually manipulated our tactics a little bit, revisited why we were getting so much pushback. And perhaps it was something that we were doing in terms of lack of education and, lack of actually framing the product as something that would be beneficial to our population. And what we came back with is that a lot of patients said, I don't want to sign up for something that I don't know what it is. Or, why would I ever need to use that if I can just call you to schedule my appointment or call you to give me my lab results over the phone? So little by little, we've actually started seeing some great success in getting people to sign up for the patient portal. We've really been promoting the company website. You see our homepage there. And, through diligence, we actually have all of our pages available in English and Spanish. So it's a little bit more accessible to the population who might be first generation, might not understand the language. Everything is in a format that's a little bit easier for them to understand, make them more comfortable. If we can go to the next slide, please. So part of the process, as I mentioned before, was the education. So we've actually taken the time to show our patients while they're in the exam room, prior to the doctor coming in, but after getting, the ROS and health information, all of that stuff out of the way, we do have some tablets that are floating around in the offices, and the MAs are kind enough to, jump on and show the clients what exactly they can do with the patient portal. So we open up, we have a dummy account, test account, so they can see, through your patient portal, you can pull up your health record. You don't need to call us for immunization records. You don't need to call us if you want to just look up the lab results, for your child, or if you don't remember when his last physical was, all of that is accessible there. So parents seem to like that. They also like that they can print out all of this information from their home or work or library or wherever it is they're going to do it. So they have accessibility. They don't need to rely on us 100%. They can be independent, and here's a screen cap of what they see when they log onto their patient portal. So they're going to see the documented allergies, the latest results in terms of height and weight. A lot of parents love that because the school asks for that information. So they're able to give that information for them. They're able to print out the visit summary from their last well visit to give to the school, so they don't have to come to us for a school form. Unless the school absolutely needs it. They also have the ability to message directly to the office, which a lot of our patients didn't know there was a capability to do that. And a lot of times it's easier for them because it's something they can do on the go. They don't have to sit on the phone waiting on hold. I'm sure everybody here knows how busy season gets, and sometimes even though you try your hardest, you might have patients that are on the phone for, 3, 4, 5, 6, 7 minutes, either being placed on hold or, trying to find them an appointment. Sending a quick, secure message to us via the patient portal is so much easier on us and on them. So if we can go to the next slide, please. And then, here they can see, like I said, their health record, their health profile, all their results, their documentation, like visit summaries, medications that we've prescribed, because that's a question that we get asked a lot. What medication did my doctor prescribe? I don't remember. It sounded something like this, or I think it started with this letter. So the patients have access to that now, so they can see. And one of the cool things that we have through our patient portal that patients seem to love is that they can ask for a renewal, a refill. Can't tell you how many hundreds of phone calls we were getting every day. Oh, my son needs a refill on this, or my daughter needs a refill on that. Now they don't have to call. They can just send a request through the system, the patient portal. It comes directly into our EMR. The doctors review it, either sign off for it or make a note that the patient needs to come in because they haven't been seen for over a year or something. It's to the doctor's discretion. But it just makes the whole process a lot easier. There's less confusion, and the patients are really happy with that. So is through that education and kind of explaining to them all the functionality through a patient portal, being able to request appointments, being able to look up just anything related to their child, it really seemed to have a lot of success. And it also gave our staff the confidence to talk about the patient portal. Because when we started, we were just kind of telling them, oh, tell them to sign up for this. It's going to benefit them, but they didn't know how to frame it. They didn't know how to phrase it. They didn't know how to sell it, basically, to our population. And that's what was leading to, the pushback. And now with the best thing we did was train all the staff, make sure all of our staff actually signed up for the patient portal themselves so that they took time to play around with it, see how easy it is to use it, so that we weren't promoting something that we weren't using or we didn't know how to fully use to our patient population. I think there's another slide. I'm not sure. Yeah, so here's the appointment request module. And, here they can state, what is the appointment for? Is it for a sick visit? Is it for a well visit? Do they want to, is it behavioral issues or, concerns about weight? They can select the preferred provider, which, we have patients that come in that they like to only see one provider, and they can select whether they need it as the first available or at their date range. Lower down on the page that got cut off, but they can select even a time that they would like to come into the office. So it's nothing better than that. They can put in the request, and then we can let them know, yes, we have this date and time available for you, or we have this date, but maybe not that time, or we have that time, but maybe not that date. But in any case, it just makes the whole process easier. They don't have to sit and wait on hold. And, we just frame it to our patients in the sense that this is just going to make their life easier. They don't have to come and talk to us because, sometimes they get frustrated. They don't have to wait on hold. They don't have to come wait in the office to, get a printout of an immunization records. They can just do all of these things on their own. So, while we are happy to help them with that, of course, not to discourage them or telling them that we're not going to help them. They do have the independence, and it seems that a lot of parents are more than happy to do things on their own, DIY it, and just come to us when they really have some major concerns. So that's basically what we did, and we've been seeing a major increase within the last 6 months of people signing up for the portal. I mean, we've advertised it all over all of our office locations, flyers and big poster boards, visit us at our website, sign up for our patient portal, so it's just basically how we found success doing that.
Great story. Great. I love the way you really engaged your parents and caregivers to identify what the problem is or was. And you asked them, and they told you. And you took advantage of that, and good use of wait time, too, in the exam room, and engaging your MAs so that they feel that they're really part of the team. And the training that you did to give them the confidence. So, again, you may be a small organization, but the lessons that you've learned can be really tested by any size practice. So thank you so much for sharing that.
No problem.
Well, we have some questions, there aren't any questions other than the one that was addressed already about ER intervention. Oh, I do. I take that. There's a new question that just came in for Casey. Please speak a little more about the details about the drawbacks of data difficulty and timeliness of reports.
Yes, this is my favorite topic. So we have lots of issues with our data. So we get various reports from different payers, and typically, I would say on average, on a good report, we get the claims back 3 months later. So a lot of our ER reports, they're not right when it's happening. By the time that they've sent us the reports, it's already too late for an intervention. I mean, really, at that point, it's just more of an educational thing. So it's very difficult with the timeliness and then the accuracy of the data. I think I'd mentioned it before that the data that we do receive from our managed care plans may not truly be accurate. We have a large patient population, and so we have, I would say, on average, to our patient panels, probably anywhere between 500 to 1,000 added monthly. And of course, some are leaving, some are going. So really keeping up with the changing data every month. I have a team myself of 2 other people who look at all of that data. So we constantly feel like we're chasing our tails, trying to figure out what's accurate, what's not. And then, like I said, we get the reports 3 months after the fact if we rely solely on our managed care reports. We do get reports back from the EDs, which those are nice. But like I said, having it all in one place is a lot easier. So that's something we've been working on with our managed care companies, and some have been really compliant in providing us with better reports. So it definitely doesn't hurt to ask them.
Good comment about that. But the fact that you're also working directly with your EDs to try to get more timely information, it sounds like you're still working out the process of the best way to get that information from the EDs that your patients are seeing. But I know that that's a work in progress. So more opportunities for improvement. Sounds good.
Exactly. And our care coordinator handles a lot of that. She's phenomenal and has great relationships with all of them. So she's definitely been working tirelessly trying to improve that.
Good role for absolutely for whoever is in that role of care coordinator. So thank you for sharing that.
Thank you.
All right. So I'd like to thank all of our innovators for each one of you have really shared some important information this afternoon, and we thank you for your time and your commitment to this work and the ongoing the ability and willingness to share with everybody. So thank you. We have just 2 quick polling questions we want to ask those of you on the line. Just going back to some of the strategies we've discussed on prior Pediatric Learning Network webinars, wanted to ask you about the use of shared decision-making techniques with either your patients and families, or if you're a coach, with what's the most common approach with the practices that you're working with. If you could just point and click and choose your answer. We would appreciate knowing that. Can we have the results? Okay. So I think we've seen a shift in this since the last time we asked this type of question, that it's being worked on, or within the next 6 months. It's kind of on the docket for at least 75% of you. So, and great to see that over about 13% have already implemented this in the last few months. So good work. The second polling question has to do with what we're talking about today, the use of e-tools to communicate. If you could all answer this question: is your practice or the practices that you're working with, if you're a coach, using e-tools to communicate? If we can pop up the responses. Okay, so again, over a third have this on their thinking about this in the next 6 months. Nice to see that almost another third are either have been working on this, or even a quarter have implemented this in the last several months. So, and even some with a mature use of e-tools. So, if there's anything in particular that wasn't talked about yet today that you would like to share, your experiences and your lessons learned with everybody on next month's call, please shoot me an email and let me know, and we would love to have you as a practice innovator. So moving forward, just want to note, we know that many of the practice teams who are engaged in this important initiative are still working on paper records. So if you are, or you're a coach of a practice, small practices who are still haven't moved to an electronic health record system, just wanted to point out that this is a great website. It has good information about the steps, starting from the actual planning, assessing for planning for readiness for an EHR. It is step-by-step, it is vendor neutral, and if it can be a good opportunity for a practice team who hasn't yet, or hasn't made any decision about an EHR. The website's included at the bottom. And on the next screen, you can see that it also has a lot of good information about lessons learned from the field. From those of you who have taken this journey, lots of people have shared their experiences. So those of you who are yet to do it don't have to reinvent the wheel. Sometimes it's good when you're later to adapt or adopt technology, because you can learn from those who have come before you. So think about this, share this, coaches, share this with your practice teams, because it really is obviously an important step. And when we're talking about use of portals, patient portals, it really is due to an integration with electronic health records. So I would encourage you to share this resource. Next slide, please. I found an interesting article when I was working on this presentation for today about an e-tool that specifically was tested for improving asthma care management. This article is actually posted on our Pediatric Learning Network resource webpage with all the supporting materials as well. This was a feasibility study. It was done at Children's Hospital of Philadelphia. It was a randomized control trial. They had controls and intervention practices that participated, and they used a tool called My Asthma. And the results of this over the course of the 6 months were very interesting. It showed that at more than half of those patients, the parents used it during at least 5 of the 6 study months, and that it was used even more often when they were patients who had moderate or severe persistent asthma. And overall, to see that over 90% of them were satisfied with this as a tool, really because it increased communication with their practice and helped them manage their child's asthma and raise awareness. All good things. And I encourage you to, maybe as a team, to read through this study. It may give you some good food for thought. And even the outcome that for these practices, yes, it was only 3 practices, but it was noted that there was a lower frequency of asthma flares and less days of work missed by parents. So it was, a meaningful study on feasibility and acceptability for a portal tool. Next slide. This just shows you the type of workflow or schematic of the flow of information and communication. You can see that when a parent actually completed the treatment goal, recorded the treatment goals, that information was shared through the EHR with the practice team. When they did the monthly report, that the information was shared with the practice team, so that there was communication to the primary care team who was managing this family, the children with asthma. On the next slide, you can see that, look at this, I love this, on a monthly basis, this is the monthly check-in results viewed over time. Very user-friendly. The use of the colors of, of green being go, that it was good, caution where for yellow, and months where certain things that were reported by the parent were a red because they showed a lack of control for the child's asthma. So you can see over time, both the family and the practice team, how that child's asthma is controlled or not. And then on the next slide, you can see that there's actually also a report that's generated of those check-in results, those monthly check-in results. And here's the report that was printed out for the family when in an uncontrolled situation, and the fact that this has been reported to their to the practice, and that and then the practice team will be in touch. Or alerting them that they should reach out to the office to discuss this with their primary care team. It's just a great example of really active patient and caregiver engagement, and food for thought. This is a tool that may be available in I don't know if it's currently still available, but you can even, you can reach out to the author or to the Children's Hospital of Philadelphia and see whether or not there's a similar type of tool available that you may be able to use, or this one that was called My Asthma. Next slide. Another example of an e-tool, Open Notes. This is an interesting opportunity. You can see how many patients now have online access to their notes, whether they're at the primary care practice or the specialty practice that they're seeing for their asthma management, or obviously for other reasons as well. It's the notes, the visit summaries and notes that have been generated and are in the electronic health record or other types of technology that are linked to this Open Notes system. Specifically for pediatrics, on the next screen, you can see that there's a toolkit specifically for pediatrics and adolescents. So that it can be used to be able to help encourage families to actually use the information that's available, that can be available through the Open Notes portal that links to their provider's electronic health record. It's just another use of an e-tool for improving communication and care management, so that everybody, whether it's the family or the primary care practitioners or the specialty care, anyone who is co-managing this child, everybody's on the same page and can share communication. We posted on our website the informational handout for parents, patients and parents about Open Notes. It may be, just give you some food for thought about whether your organization, especially if you're part of a larger academic organization, who, may be able to then link to and use Open Notes or make Open Notes available for use. So just another example for you to think about as an e-tool. This brings us back. This is just a reminder about another aspect of person and family engagement, the improvement strategy that we discussed during our first webinar a few months ago. If you haven't yet created an asthma registry to identify who your patient population is and define that, so that then you can track that, as you heard about from the, some of the innovators who shared what they're doing with us today. Remember, it's not too late. Don't think, well, I can't do that now. Now's a perfect time to think about creating that registry or helping your practice teams that you're working with, if you're the coach, set up, at least start to develop an asthma registry, whether it's an Excel spreadsheet or it's using an e-tool, or it's part of the electronic health record. Flu season's coming. Now's the time that you need to be recalling those patients with a diagnosis of asthma for their flu shots. It would help you to be able to track that, who's coming in, who needs to come in, by using a patient registry. And as we heard today, being able to use it for referral tracking and follow up when patients seen in the ED, all good reasons to be able to really put a registry, an asthma registry, to use. So I encourage you, if you haven't done it yet, start with a PDSA and think about how to develop your practice, your asthma registry for your patient population. Next slide, please. As usual, based on each month we've met, I've challenged you to look at I've introduced an action item for those of you who are participating, and this month's has to do with the recruitment and or use of your patient portal or another e-tool to improve communication with your patients and families regarding asthma care management. So here it is. Add this when you have your next meeting as a team, and think about if you haven't yet started recruitment, maybe that's where you're going to focus. If you've already tried doing recruitment for a portal use, what could you do a little differently? And it may be asking your patients what they need or how they want to receive information, the type of information that Rolando shared with us. On the next slide, just a reminder that this is about quality improvement. So use your QI methodology to be able to put this action item into practice. And remember, on the next slide, every time I say, this is a team sport. Great to hear the involvement of parent and caregiver partners in the work that's going on, and everybody else, the MAs, the front desk staff. It doesn't matter if you're a small practice or a large practice. This is, bring the team together to continue to do this work. On the next slide, if there are any comments or questions or anything you want to share in the last few minutes about the work that you have been doing as a result of this initiative and maybe this Pediatric Learning Network in particular, please, I think we're going to unmute the lines, and if you can just jump in if you have something you want to share. I know it's always a quiet group, but or type it into the chat box. Okay. Well, again, if you do have something that you'd really like to share with everybody, please let us know, and we would love to help you prepare to be an innovator on next month's call. Next slide, please. Just a reminder, here's your assignment for the coming month. Hope you will take on the challenge if you haven't yet been working on a patient portal or other use of another e-tool. And the other reminder is that we're meeting again. The 5th and final webinar will be next month, September 19th, same time, same place. And our topic is going to be connecting patients and families with appropriate supports and services. So if this is a topic that you would like to share what you've been doing or what your practice teams have been doing on that topic, please let us know. You can be our innovators. Reminder, here are the website links for the resources that have been posted, both for the SANS website and specifically for the Pediatric Asthma and Person and Family Engagement. And thank you all for your time and continued commitment and effort to the work that you're doing. I know this is not easy, and you have a lot going on, but you're taking the time each month to continue to join us is greatly appreciated, and we're here to support your efforts.
And Ruth, on behalf of the Patient-Centered Primary Care Collaborative, thank you so much, and thank you to our practice innovators for some really great examples of the kind of work you're doing around asthma care. So we appreciate all of your participation, and we encourage you to look up the information and the resources on our website. And with that, we'll close our call. Thank you so much, everyone.